There we go. All right, so welcome everyone. We'll start off tonight with some introductions, and then we'll turn it over to Adam for his speech or talk tonight. We'll have a little break, and then we'll do the innovation presentations and discussion. Um, so maybe we can start with introductions of students, and then we can finish up with Adam. So I can start. I'm Katie Kerr. I'm the instructor for this course, Adam. And I've been with the college for, gosh, 11, 12 years now. I'm the program director for the MHA program and for the Masters in Health Informatics and Information Management. So, um, the question here, do you use AI in your day-to-day life? I feel like I'm using it quite more and more in just developing unique coursework and things, and the college has partnered with Google. So that's exciting for me. I know there's a lot more education and things coming down the pike for us and for our students. So I think I'll maybe call on Angie to introduce herself.
Hi, I'm Angie DeBruzzi. I am currently an imaging supervisor for Fairview Health Systems in the Twin Cities. Um, as for AI in my daily life, I actually probably use it at least twice a week. Just trying to say, how can I rephrase this in a different, like in a not so formal term? Um, and then I think my organization is implementing AI. It's not. Um, totally there yet, but I think they are going to use it for a lot of the platforms in radiology for CT and MR and that kind of thing.
Thanks, Angie. Patrick.
Hi, I'm Patrick. I'm currently a case manager at Ascend Services, which is a community mental health center in Duluth, Minnesota. And I actually just used AI today, to create a name for the app that I made for my little project later. Um, and my organization as a whole isn't implementing AI, but I do use it in my job sometimes. If I don't know what sort of resources out there, I may use it to have it come up with a list. So yeah.
Great. Thanks, Patrick. Becky.
Hi, I'm Becky Keyser. I live in Paynesville, Minnesota. I work out of Essentia in Duluth. I am a remote health information supervisor. I just started there last week. Um, and very timely, we did actually have a meeting on this. The health information department is dabbling, I should say, in AI. They have the tools out there for, Office 365, and our director seems to kind of want people to like play around with it. Um, Day-to-day life, I've used it for touching up resume. Concerns I have about it though is the hallucination portion that it's still doing. So, but yeah, good to meet you. Thank you for presenting tonight.
Thanks, Becky. Nate.
Hey Adam, it's good to see you again, and thanks for being here. Um, Nate Meyer, I'm up here in Duluth, Minnesota, clinical quality coordinator at Ecumen Lakeshore, so in long-term care. Hoping to transition out of that soon. Cohort one student for 3 more days, which is a bit odd to say. I've been using a lot of AI just in my day-to-day life, especially with my capstone. It's kind of like the perfect research assistant. And then I think it's kind of a blind spot we have at Ecumen right now. We have kind of the tools, like Becky said, we've got Copilot, Microsoft 365, that whole suite, but I don't really see it being encouraged or utilized. So I try to implement it into my workflows, but I think it's an opportunity for us as an organization. And thanks again for being here, Adam.
Yeah,
Great.
well, thank you for having me.
Yeah.
Absolutely. And I can kind of do a quick intro of you, Adam. I don't want to take all the words out of your mouth, but Adam is just been a really incredible partner of the program as long as I've been here. He was one of the big reasons I got involved in the American College of Healthcare Executives. Him and our regent David Walls were two really, I guess role models in that way. He currently works with Mayo Clinic for their Platform Accelerate program, which he'll talk more about. And he's kind of the perfect one for innovation, helping with, AI startup companies leverage data, helping them improve their products, improve lives of patients. Um, he does have a master's in management analytics from University of Toronto and a BS in computer science and data analytics from Drake University. Are you still in Madison, Adam?
I actually moved to Houston a couple months ago, but this is
No way.
not far off. Yeah.
Well, I'm out of date. Well, I'm out of date. So you're down in
Yes,
Texas,
yes.
and just been lovely to, be able to kind of work alongside you and learn from you as both a student and kind of a professional within the program. So appreciate you being here, Adam.
Yeah, wonderful. I can share.
Yeah, Adam, I'll stop. And then,
Perfect. Here we go. Awesome. Well, that was a great introduction, and it was really nice to hear about each of you. And like I think within today's talk, I'll talk a little bit about a lot of the work that you already do. Mental health work, radiology, health information management. Like that's all directly within the scope of the kinds of companies that I work with. So I'm really excited to talk to you all today. So like Nate said, I work for Mayo Clinic, and what I do is I help startup companies, so early stage companies that are, just getting founded or within their first few years of being founded, that are focused on healthcare AI, to build their product in partnership with Mayo Clinic. And in the past, I spent 3 years as a management consultant for Mayo Clinic. So I worked with different leaders, clinical leaders, research leaders, operational leaders across Mayo Clinic to make like big decisions, like market entry, like what should we do in this country, or how should we, expand this service line. So I spent 3 years also working across Mayo Clinic in all of our different sites and all of our different, parts of our organization. So just to talk a little bit about the context that I kind of come from, I work at Mayo Clinic, which obviously, you probably all are familiar with, being in, the Midwest. So we have this is a couple of years old. We actually have now over 100,000 employees spread across Minnesota, Arizona, Florida, and Wisconsin. And the part of Mayo Clinic that I work in is separate from our clinical practice and our research and education. And it's called Mayo Clinic Platform. So it's a department of Mayo Clinic. We're still part of Mayo Clinic, but we're, not attached to just one part of, Mayo Clinic's mission. We work across our clinical practice, research, and education to enable healthcare innovation. So we have about 200 people in Mayo Clinic Platform that are helping build and deploy AI algorithms across the world. And what we've done is we've taken data and we've de-identified that data and created a de-identified data set that allows AI algorithms to be trained on that data in a privacy protecting way with trusted partners and researchers. So we allow, researchers to get access to de-identified data to improve the care of improve clinical quality across the world. So, we have researchers that are looking into, new treatments for cancer, or new predictors of cancer, or looking into new ways to detect disease earlier. And I'll talk about a few of those examples, like how people are using AI in new ways in a little bit. But this is kind of what I do, is working at Mayo Clinic in our area that's helping build and deploy AI. And what I want to talk about today is a few different things. First, I want to talk about why AI is essential. So that's kind of the foundation of this discussion today, is like, why does AI matter? Then I'll talk a little bit about like what types of solutions companies are developing. And then we'll talk a little bit about how like an idea for an artificial intelligence application goes from just being in somebody's head to being implemented based on, my experience in the Mayo Clinic Platform Accelerate program. So I want to start by talking about why is AI important, because I think we get a lot of discussions in society today about like risks of AI, or cool new tools, or how AI is going to take everybody's jobs, or things like that. But we don't talk a lot about like why are these tools even being developed? Why is it important? Why are institutions and leaders exploring the development of these tools? And why, as future MHAs, is it important that you understand AI and know when to adopt and when not to adopt artificial intelligence tools? So just to do a quick recap, I'm sure everybody knows like the quadruple aim already from earlier classes, of like improving healthcare outcomes, improving clinician experience, improving patient experience, and lowering cost, and how within healthcare we try to simultaneously make improvements in all 4 areas of these different domains at the same time. And right now, this is becoming more and more difficult each year. And I'm going to talk a little bit about some indicators of that statement. So like if we look at the life expectancy of the United States, it really hasn't gone up since 2009, and it still hasn't fully recovered. We don't have like the official data yet for 2024 and 2025, but we don't, according like with the official data, we haven't had an increase in life expectancy really since 2009. So within the United States, we've really flatlined in terms of our improvements in improving, how long people are living and how many healthy years they have. If we look at the clinician experience of, physicians or like my wife, she's a nurse practitioner, or nurses, or other, caseworkers and, anybody who works as a clinician in healthcare, many people are burned out or depressed. Like if we look at a recent physician survey, about 50% are burned out and about 25% of physicians are depressed. So we have this huge burden of clinicians that are being overworked or do not have the capacity to continue working in their role. If we look at cost, we spend, so every single dollar, if you take every single dollar that's spent in the United States in a year and you throw it into a huge pile, maybe the size of like a building, 1 out of every $6 is spent on healthcare. So you'd have to grab 1 out of every 6 of those dollars, and that would be just the money spent on healthcare in this country. And this is 30% higher than it was in 2000. So the percentage of our spending on healthcare has gone up dramatically. And you can see it's been a steady increase since 1970. So from 1970, when we were below 8% of our national gross domestic product on healthcare, we're now almost at 18% and getting close to 20%. So we're spending more. We're not getting higher life expectancy. That's plateaued since 2009, and everybody's burned out. And if you ask patients, their perception of quality has only really gone down since 2001. So patients, if you look at the Gallup surveys, like how would you rate the quality of healthcare in this country? Patients, about 53% of patients rated healthcare quality as excellent or good in 2001. Now it's down to 44%. So almost a 10% decrease. So it's not like, we're spending more and we're getting outcomes that at least people think are better. It's, people also are thinking healthcare is getting worse. And this problem is only going to get worse. So we have about, if we look at the 65 plus population that requires a majority of the healthcare in this country and is concentrated users of healthcare, the number of people that is 65 or older is going to increase 30% between 2025 and 2050. So we're going to have a lot more older people in this country. And by 2030, it's projected that immigration will overtake the natural increase as the primary driver of population growth for the country. So this was from a couple years ago. So like these population projections with 30% increase of individuals 65 and older between 2025 and 2050 are assuming quite a bit of immigration to this country over the next 25 years. So whether or not that's like optimistic assumption or not an optimistic assumption is not, it's kind of not something that we're going to be able to determine in our session tonight. But like even if we are assuming that there's a lot of migration, the workforce size in this country will only increase 10% between 2025 and 2050. So we're going to have a 30% increase in the number of older adults. Most optimistically, we'll have 10% more people. So we're going to have more people to care for and less people available in the best case to take care of them. So this is really why AI matters. We have this in the past, we've been able to kind of scale up our workforce size and spending with the needs as they've grown for healthcare in our country. But in the future, like you can see pretty, clearly, like we're going to have a lot more people that need healthcare. We're not going to have many more people to deliver that healthcare. So this is where we have to have innovation and automation within the healthcare system. and even more than most other industries, like let's say farming. I don't know if people have spent a lot of time on farms, maybe you have. There's been a lot of improvements in automation in farming. There's automated combines and automated, my coworker, her son runs a spraying from drones for, diseases and for pests and stuff. Like there's a lot of automations you can deploy in farming or other manufacturing-based industries that cut down the amount of labor required to produce something quite dramatically. But today, and how it's looked like in the past, healthcare is a very it's a industry that's relied on a synchronous relationship between the amount of time a clinician spends and the amount of care that an individual receives. You need to have somebody see that patient for a certain amount of time in order to understand what's going on with them, come to a diagnosis and develop a treatment plan. And that's been pretty consistent over time, that the more care needs there are, the more treatment we need to deliver. But this can't be true in the future. We can't have this same relationship between care needs and the amount of time that we spend from a human being, because that model will not last until 2050. So it's essential that we have innovation and automation that allows us to use a relatively flat or slightly growing workforce to deliver more healthcare and meet these needs of an aging population. So when people talk about AI and talk about, things that can be done with AI, to me, it's less about like the fun stuff, like making a fun poem or generating a fun image. Like really AI, we need AI that helps to automate and innovate to meet healthcare needs. So this is a summary of why AI matters. And it really matters because we have these future challenges that we're not going to be able to meet with the same workforce and tools that we have today. So that was kind of the sad part of things are challenging and or there's a lot of challenges for the future. So let's talk about how there's opportunities and exciting things that companies are doing to meet this challenge. And there is hundreds, probably even thousands of companies across the United States that are doing really key work directly in this domain of automation innovation to close care gaps. So let's talk about a few of those. And first, let's talk about at a high level, how are companies innovating? So today, we have a very episodic healthcare model. So when you interact with the health system is in very small, very discrete ways. Like you'll go to the, you'll go to the doctor maybe every year for a physical, or maybe you feel sick, so you go to urgent care. Or maybe you have some sort of recommended screening, so you go in for that screening. These are very episodic, but the amount of information available about you as a patient is very narrow and contained to a very short window of time. The doctor only knows about what's going on with you during that physical and then, knows your status at that time. Let's say something new pops up 3 months later. They have no idea unless you go back and have another visit with them. So a lot of companies are working to build this more continuous model of healthcare. So this is where your health, maybe there are these periodic updates that provide a lot of data and information, but we integrate more continuous sources of information to help your care help identify diseases that you may face and also deliver you care in between these more major episodes of coming for a face-to-face visit or getting some sort of scan. So we'll talk a little bit about Apple Watch ECG reading. That's a great example of moving towards a more continuous model where your healthcare is monitored and maintained even without a direct face-to-face visit with a healthcare provider. So here's what it looks like today in an episodic care model. If we're talking about diabetes, you have a wellness visit, you're screened maybe every few years for diabetes, you get a blood sugar measured. Let's say you have a high blood sugar and your blood sugar doesn't look very good. Then maybe you're determined to have pre-diabetes, and then you get screening every year for your blood sugar or every 6 months. So then let's say it's every year, between those yearly measurements, there's very little information available about your blood sugar or how your disease is progressing. And you could even go, 6 months, 8 months without knowing that you have progressed to diabetes because it wasn't measured in that period of time. So this is, this is how it looks today. You are healthy, you get very little screening, you are identified as having some sort of condition. Once you already have some sort of, markers of disease, then once you are diagnosed with that disease, you get a lot of care. You have a bunch of visits, you get a bunch of medications, you get a bunch of education and management of your complications. So in the current healthcare model, when you're healthy, you don't get much screening. Once you have been detected to have some sort of disease, you get some screening. And once you have a disease, you get a lot of care and very expensive care and a resource intensive care once you're already sick. But the resources to manage your disease are really concentrated on this sickness phase once you already have the disease, when really it would be better both for society and for you as a patient if we could manage your disease more at this healthy or pre-diabetic stage, so that you never even get to this diabetic stage where you need to have all these expensive interventions. So this is what it could look like more as a continuous model. Patients that are healthy are stratified into risk. So before they even have any symptoms of prediabetes, there's risk stratification, maybe based off of your age or your family history or vital signs or biometric kind of measurements. So stratifying risk and then doing, personalized prevention and education plans based on your risk level. Using more continuous monitoring of disease if you have some sort of warning signs for diabetes. So maybe really early on, if your blood sugar is consistently a little bit high, you get a continuous glucose monitor. So rather than, only getting a screening once a year and you don't even know you've progressed to diabetes until 6 months after it's happened, you have this monitor that's telling you, oh, wow, okay, you're getting really close to diabetes. You need to make an intervention. Or some sort of digital health coach that's helping you to, modify behavior even when you're not yet diabetic and does not require a human being to be delivering that education. And then once you're diabetic, AI to help improve your dosing, to manage your disease without having side effects from your medication. Having like AI to detect conditions that are prevalent with people with diabetes, having wounds that are not healing or having diabetic retinopathy. So, once you have diabetes, using AI to do early detection on the complications of your disease. So if we think about kind of moving from this episodic model where, you get a screening every 3 years, then maybe you get a screening every year, then you get a bunch of care once you're actually sick, to this more continuous model of we identify who's most at risk, we help them prevent becoming high risk. Once they're high risk, we monitor and make interventions digitally and continuously. And then once you're sick, you use AI to improve the care as much as possible. So this is kind of the opportunity that many companies and researchers are trying to build today. It's like even within diabetes, there is hundreds of companies that are working in this space in the, like in some of those complications, like I mentioned, podiatry and ophthalmology, in developing new drugs, developing virtual care options, digital therapeutics, like devices to deliver medications, monitoring glucose, diagnosing the disease earlier. And there's, if there's like 100 companies on this screen, this is going to even double every year. Half of them will go out of business, another double will replace them. There's constant innovation in any sector of healthcare with hundreds of companies working to build out each of these kinds of tools, because each of these different ideas could have 10 companies that are working to build that. So this is just a kind of a snapshot of diabetes, but this could scale to any condition, cancer, heart disease, like musculoskeletal conditions and so on. So let's look at a few specific case studies of how AI is being used across healthcare. So here's a few different domains that we'll talk about today. So we'll talk about diagnosis of disease, treatment of disease, fraud detection, triaging patients, administration, and then, new applications of generative AI. And this is just a few examples. There could be 20 more different domains. So let's talk about diagnosis. And this is something I referred to a little bit earlier. But so how are algorithms being used in the diagnosis of patients? So algorithms are being used in a few ways. So one, AI is being used to take new different types of data that previously was not useful to make clinical decisions and make that data set of, help it turn into an actionable insight for a clinician. So like one example I'll talk about in a second, like a one lead ECG. If anybody knows much about ECG, typically there's 12 leads that are like the most common clinically relevant tool used to detect disease. Like a one lead ECG would be really hard for a human being to interpret because it contains so little information. But an AI algorithm can use that one lead ECG, even though it is such a noisy signal, to detect disease, because the AI has, essentially like a superhuman eye, you could think of it as, that can see even really subtle patterns that a human being could never detect. Diagnosis is also being transformed by algorithms that are helping clinicians to make a diagnosis decision. Like let's say a patient presents to the emergency room with like stomach pain and, they've been vomiting and they have like weird blood work. Like, is this a patient that needs to have like a really expensive imaging exam? Is this a patient that just has the flu? AI can take all those symptoms and help provide clinical decision support to tell the physician, like, this is probably the most likely thing, but, there's still a high risk of this condition that you might need to rule out. So the benefits of integrating AI into the diagnosis process are being able to screen more patients for disease, being able to detect disease earlier and have like some sort of earlier intervention, and then also like improve the accuracy of diagnosis. So like in terms of screening, one human being can only do a very small amount of work compared to a computer. A computer could take 10,000 medical records and screen every single one of them to see which patients might be pre-diabetic and don't even know it. A human being to screen 10,000 patients based on their medical record would take months. Just like I mentioned, in terms of like early disease detection, if for like radiology context, algorithms can detect very, very, very small like lesions or tumors that aren't even really perceptible to a human being to detect disease earlier, because a human being might not have seen this really subtle patch that it actually is a tumor, but it's really, really, really hard to detect. But the AI algorithm, with its ability to detect really sensitive patterns, can detect those diseases. And then in terms of improving diagnostic accuracy, missed diagnoses or overdiagnoses are really hard for patients and really costly for the healthcare system. So, even if we can just like help prevent 10% of early stage cancers that are missed, or help 10% of patients that actually maybe don't need a biopsy that are getting one, by the use of an AI clinical decision support, that makes a huge impact. So here's like a case study. This was done at Mayo Clinic. So this is a study where they took Apple Watch users and they captured this one lead ECG. So like I mentioned, this is a pretty hard signal to interpret clinically a lot of the time, because it is like a pretty limited window into heart activity, but it's able to be captured by your Apple Watch. So they took patients and they enrolled patients that we had an Apple Watch and got 125,000 ECGs that were uploaded to a cloud platform and had an algorithm to detect left ventricular dysfunction run on the one lead ECGs. And so they had about 2 ECGs provided per month, and 92% of people submitted at least 2 ECGs. And what they did was about 420 of these patients ended up actually having an echocardiogram ordered for them, like unrelated to the Apple Watch study. So they were able to tell for these 420 patients, like, was the algorithm accurate or inaccurate based on like the actual, test that is used to detect left ventricular dysfunction, which is an echocardiogram. So of these 420 patients that had a echocardiogram performed, the algorithm, based just on their Apple Watch results, was just as good or slightly better than a medical treadmill test at detecting left ventricular dysfunction. So even just from this one lead ECG, due to the power of algorithms that are able to detect really subtle patterns, they were able to get result about the same as a medical treadmill test from this device that is somebody is continuously wearing. So rather than needing to like become symptomatic, like, oh, I can't, run anymore, or, oh, I have chest pain, Rather than needing to become symptomatic, they were able to detect this disease remotely from their Apple Watch. And this is exactly that, an example of that can shift from episodic, like, oh, I feel sick, I wait 2 months to go to the doctor, I go to the doctor, I'm diagnosed with the disease, to continuous. I wear my Apple Watch, the Apple Watch detects that I have a disease, I'm notified that I need to go get some sort of intervention to help improve that condition before it gets too bad and I'm actually symptomatic. And there was limitations on this. This is still only 420 people, and like not everybody has an Apple Watch. It's pretty expensive, and like the participants weren't super diverse, but still is a interesting, exciting application of like that shift from episodic to continuous healthcare. In terms of treatment decision support, so this is like deciding which treatment that a patient gets. Algorithms are beneficial because they can personalize the treatment to the exact characteristics of the patient. So I'll tell a story that my boss, Dr. Halamka, Dr. John Halamka at Mayo Clinic likes to tell. Like his wife was diagnosed with cancer, I think about 10 years ago, and when they were deciding on her treatment plan, sure, it was really important to her that she didn't get like neuropathy, like, her fingers didn't lose their function because she's like an artist. So that's her job, is being an artist. And if you're an artist and you can't, feel your fingers or can't use your fingers, essentially your whole, livelihood is gone. So that was her main treatment. That was the main goal of her treatment, was to, be healthy and not have cancer, but retain full use of her fingers. And so what Dr. Halamka did, he's an emergency room physician, he consulted with oncologists, and he actually went through every single medical record of, like in a study of recent patients that had been at his condition, or at his hospital, which was like in Massachusetts. And they looked for patients that were most similar to his wife and saw what their outcomes were based on the dose of treatment that they got. And they found that for people that were like his wife, that were like, I think she was like a very slight, like 5 foot tall, not a a very light, like young patient. If they got a high dose of the chemotherapy, they almost always had neuropathy of the fingers. And the patients who had a low dose of the therapy had less neuropathy and still had good outcomes on their cancer care. So they were actually able to take all that data and personalize her treatment to give her the exact dose that would balance her treatment goals of resolving her cancer with not having the side effects that would, lead to an adverse outcome outside of her, cancer. And she, today is alive and healthy and doesn't have cancer anymore, didn't get neuropathy in her fingers. And that story that was done manually. That was done by people, because this was like 10, 15 years ago. But that is the promise of AI, is that rather than needing to rely on studies like all women should get this drug or all people over the age of 75 should get this drug, we can personalize the treatment of each patient based on their exact characteristics using an AI algorithm that has been trained on, thousands or hundreds of thousands of patients in the past. So that is the promise of AI, is to personalize care to the exact characteristics of each patient, while also integrating medical knowledge that would be impossible to train one person on. Like one person's not going to know every clinical trial and the result of every single drug that's being tested today. So even in a small subspecialty, like, a certain type of cancer, you're not going to be able to know everything. So that is the promise of AI as well, is that AI could read 50 papers a day and be able to integrate that knowledge into a treatment decision support, rather than, a human being that can only read so many papers per day on top of their day job. So another really important use of treatment decision support is relying less on scarce specialists. So today, there's not many oncologists, there's not many cardiologists, there's not many GI doctors. And like, if you've had to go to a specialty care visit, often, like you would already know, you may have to wait weeks or months, especially in a rural area or in a country that doesn't have a lot of doctors. So if we can use AI to help reduce the dependency on scarce specialists, we can give healthcare access to more people. And that's, one of those goals of the quadruple aim. So here's an example of another company that is using data to personalize treatment. So this is a company called Genomate. What they do is they take your full profile of a tumor when you have cancer and all of your genetic test results. They analyze all the genetic alterations in your tumor and in your body to come up with the best predicted drug for your exact tumor profile based on your demographics and your exact tumor. And recommends to the doctor, here is drugs that you should consider for this patient based on past patients, what's going to work the best. So this is, this is a perfect example of taking the genetic markers, predicting which drug is going to be most effective to help recommend to a doctor which drug to try. And the doctor can, still choose to go in a different direction. That's kind of the stage that we have today in AI. Is a lot of this is like decision support. So it's information to a doctor, but it can be really useful if you're really stuck as a doctor, not knowing which treatment to go forward with, having a second set of eyes from an algorithm providing a recommendation. Another use case is in fraud. So it's been detected that like about 3 to 10% of healthcare claims may be fraudulent in North America. So this is like hundreds of billions of dollars in claims. This is people essentially saying like, oh, I went to this doctor and got this treatment, and my insurance company should, pay the doctor. And there's schemes or, frauds where like either people make up fake patients or there is real patients and real doctors, colluding to say the care was delivered that was never delivered. And so this is a really big problem in the industry. So the use of AI in this setting is to predict which claims are fraudulent and that shouldn't be paid before they're paid. So this is obviously good to prevent money from being stolen. So predicting which claims are fraudulent before they're paid. And then, it is able to detect these subtle trends that a human claims adjuster would not be able to detect. Like if there is a really small fraudulent ring of patients that is, only every couple years they're really coming back and putting in some fraudulent claims, a human being would very easily miss that. But with AI, there's an opportunity to be able to detect these subtle patterns. So this is an example done by MasterCard and Milliman, which is a consulting firm. And what they did was they built some models to stratify the risk of providers. So like going through all the claims and identifying which providers have like kind of, sketchy claims that don't seem like they add up or they may be fraudulent. And so they were able to stratify providers into these risk categories, and they reviewed the claims paid to the high-risk submitters. So once they reviewed these high-risk submitter claims, they found that about 70 to 80% of them were pretty risky claims that had already been paid. So they were able to detect almost $240 million in potential savings that could have been avoided by paying these claims to these high-risk providers. And a human being could never do this type of work. You could never have a human being doing this type of review in a timely manner. Only an algorithm could go through hundreds of thousands or millions of claims and identify which providers are the high-risk ones in an accurate, tailored way. So this is a great example of using AI to save money and reduce fraud in the healthcare system. So another use of AI is triage. So this is helping decide, which patients need care first. And this is to help, do more proactive planning. So deciding if a patient is going to need to be transferred from a rural emergency room to a referral hospital that's more specialized. If you can call that ambulance or call that helicopter like 30 minutes earlier, if the patient's having a really serious condition, you could save their life or improve their outcome. Triages also can make less biased decisions to improve patient care. Like let's say there's a triage nurse who just came off a shift where a patient died of a heart attack, and they feel really guilty about it. They might, send everybody with chest pain in to directly back to get assessed. Even though there's maybe patients that are having other acute conditions that, like, according to a triage algorithm, should be triaged first. But human beings have a lot of bias based on many different factors that algorithms can hopefully be trained to avoid, or at least can be tested more empirically to see how biased they are. And then also this frees up clinician time. Like if you have somebody that's spending time just deciding who gets care, that means they're not spending time actually delivering healthcare. So if we can use an algorithm to do more triage, that allows clinicians to make the most of their time and use that time for clinical decisions. So here's an example of a behavioral health algorithm for triage. This is a company called Opt. And what they did was they built like a mental health intake platform. So it allows the patient to give them a narrative and describe like what their preferences are for care. So they can, write out like what's going on with them, talk about what their goals are, talk about what their preferences are for what type of care they receive. And then it'll use AI to assess whether they're a fit for different mental health clinical practices, what level of care the patient most likely needs, which options are going to be assessed as like able to be paid by their insurance company, and which options are going to be preferred by the patient. So they did a pilot. They were able to reduce wait times by 60% in Ontario. And they were able to reduce the amount of symptoms that patients experience by 30 to 40% by getting them in faster and getting them on care more quickly. So in terms of administrative solutions, many of you work in like the more administrative side of healthcare, and that, becoming an MHA, that's like often, people you're not going to be delivering healthcare. You're going to be more helping support people that deliver healthcare. So AI has a multitude of different areas that it can improve. So, patient scheduling, getting them in with the right person at the right time. Staff scheduling, that's always a big challenge in institutions that goes relatively unnoticed. How do we schedule people so that we don't have too many people or not enough people? Hiring, billing or paying bills, and so on. And this is really allowing us to reduce costs by better allocating resources and staff, and improving patient experience by not having to wait as long, being scheduled with the right resource at the right time and having more seamless care. So here's an example of an administrative algorithm that's been deployed. So this is a company called PEP. So what it does is it goes through and it reads all the notes and all the information that's been entered into the patient's medical record throughout a hospital stay. And throughout that hospital stay, it figures out, is that patient going to need a nursing home bed or a rehab bed after their hospital stay? And then it works to generate a list of facilities that have an open bed that can meet those care needs. So this is a platform that, allows for the care needs of a patient after an inpatient stay to be determined and then matched to a facility. To save the time of social workers or others that are like calling around trying to figure out where this patient can go, or family members that are calling around trying to figure out where the patient can go. This works to solve that problem by determining the care need and then matching the patient to a facility. And the goals are to improve patient outcomes, save money and time, and reduce the amount of patients that are just waiting in the hospital without a place to go. And then finally, let's talk about generative AI. So I'm sure, like we talked about before, everybody's used generative AI. And there's a lot of uses of generative AI that are being deployed today, especially taking time-consuming tasks, like things like writing notes, and trying to automate that work. Because sitting there, typing on a computer is not a good use of a clinician's time. You really want them to be talking to a patient, gathering information about that patient, making a treatment decision, not just documenting what was already decided. Generative AI is also really valuable in unlocking structured information from unstructured text. So like today in our healthcare system, a lot of data is unstructured, things like images or notes. But this is really hard to use for analysis because, it's hard. It's not in a structured form where you can compare group A versus group B. It's in a note that, is hard to break into discrete categories. So you can actually take notes and extract out structured information from the note for research or for, detecting conditions that a patient might have. So one company that you may have heard of in the past is called Abridge. This is a company where, they have a device that sits in the room and listens to the conversation between a patient and a provider, and then it drafts a note describing what happened and puts it into a format that can be put right into the medical record. So, and it also summarizes the key points for the patient. So it has a dual function of, documenting the conversation and documenting the visit so that the doctor doesn't need to spend the time to do that, and making a patient-friendly version that they can read that summarizes the conversation in the way that a patient can understand. And like what they've found with the bridge is, it reduces the amount of time clinicians are spending after hours. Clinicians are having more undivided time with the patient and decreasing kind of the cognitive load of switching between a million different tasks to try to do documentation and patient care at the same time. So that is, a brief summary of some different like specific applications of how we're working to close this gap and innovate in healthcare. I'll just take 5 more minutes and then we can have 10 minutes for questions on how our algorithms developed and deployed. So algorithms really go into these phases. So first, assessing whether it's a good idea to even build it. Then, trying to build like a proof of concept, proving that the algorithm is able to do the job that you're hoping it can do. Then you need to work to actually bring this into the clinical workflow of the end user before rolling it out into, wide adoption. So before any AI is actually, built, it's critical that the desirability, feasibility, and viability of the algorithm are assessed. So I think if you only remember one like framework from today, I think this is a good one. This desirability, feasibility, and viability. This is asking the questions like, can it be built? That is feasibility. Like, can we build it? Desirability, like, is there somebody who actually wants this? Like, does this solve a real problem for somebody? And then viability, like, can we make this financially sustainable? Can we make this in a way that is going to be able to be maintained over time? So like, can it be built technically? Do we have somebody who actually wants this? And is it solving a real problem? And then can we make it a sustainable, product that's released into the market? Then we actually build a model or build a product. So we need to decide what model is appropriate for the problem, fit the model to past data, and then use the model to predict the future. So that's the high-level task of building an AI algorithm, is deciding what type of model is going to be appropriate, using past data to figure out how to train the model, and then using the model in actually a new setting that it's never seen before to make predictions. And this is how we do that. First we gather data. So this is what I help companies do every single day. Gather the data that they need to build an algorithm, build a model based on the type of model that is appropriate for the task. So like, for example, for like generative AI, that's some type of model that's called like a transformer model. That's a model that's really good at taking in unstructured data like text and then outputting the next sequence of text based on the past text. That's all that a transformer model does. And to build like a system like ChatGPT, you need to, gather data, gather every single piece of text from the internet, train the transformer model, and then validate the model. Like, was it accurate? Did it perform well? What do we need to adjust before moving it into translation? So determining like, make sure the product works and that it's safe through studies like retrospective or prospective studies. Integrating the tool into a clinical workflow and making sure that it's seamless to use for end users, and then making sure that you have regulatory approval for your product, like whether it needs to be regulated as a medical device or it's a clinical decision support tool, having the right clearance from the government to use your product as it's designed. And then finally, moving into application. So like, having reporting systems to make sure that it's still performing well, deploying your model and making sure that the model is, if there's any adverse events, they're noted. And then thinking about like the life cycle of the algorithm. How long is this going to be deployed? When is it going to need to be retired or retrained on new data, and so on? And so here's some challenges that I see and that others see in developing AI. There's a lot of data out there, but a lot of it is very messy. You've all worked in clinical workflows, and you see like, information is not always accurate in every single system of record that you work in. It's hard to get people to adopt AI. People are resistant to change, especially if it's like disruptive to their day-to-day work. You need to make sure your model, even if it was trained on the past, like if things change over time, you need to make sure the model stays accurate while building trust with clinicians. So you need to make sure that the clinicians, want to use your algorithm and understand how to use it, and that it meets all the regulatory requirements, which are very complex for digital health algorithms. And then there's these challenges of, how does it make money? How do you make it sustainable? Especially if it improves patient care but doesn't have a lot of billable components. How do you make a business model that allows you to maintain your model, but also, even if it's not like directly reimbursable by an insurance company? And then who owns the data? Like if your algorithm uses a lot of data, who owns that data? Is it the health system? Is it the patient? Is it you? There's these ownership questions. So I'll just finish with this. There's hundreds of AI startups that are working in healthcare. My team has worked with like 83 companies that have built AI products, but there's hundreds and hundreds of companies that are working in many different spaces, from the revenue cycle to radiology to drug development and pharmaceuticals through clinical trials. In every single sector of healthcare, there's companies that are building algorithms. So just wanted to finish there and have a few minutes for questions. But any questions from anything I covered today, or anything about the work that I do?
It's super interesting.
So,
Yeah.
Adam, so what you do, you help startups and stuff. Is that like I read like an article about the AI and Mayo Clinic and the platforms and stuff they're doing. Is that I guess what I'm trying to say is, how does it benefit Mayo Clinic to help other startups? You know what I'm saying? Is it just an opportunity to grow the technology, or?
Yeah, so like the program I work in, we invest in the startup companies. So like, when they so like we have stock or an equity stake in the companies that are in our program. So like when they, become publicly traded or get acquired, we would get like a financial return as well. But I think the main goal is not as much financial, I'd say. The main goal is really like helping scale the impact of Mayo Clinic outside of just like our physical presence. So I think that was the goal of creating like our Mayo Clinic platform, was to scale the impact of Mayo Clinic beyond our walls, like help more researchers and like innovators to get access to the resources that they needed to build AI and build innovative products. So I think, the financial part is more like sustainability, because I want a salary and, you need to pay the bills. But I think the main goal is impact. But yeah, it's a
I
great question.
thought I thought that the part of the presentation where you talked about like continuing care, and then you had like the green and the yellow and the red. I thought that was super, super interesting. And that there's definitely some areas of opportunity there. I thought that was super cool.
Yeah, definitely. And I think like as you all move into more like roles, like advancing your career into leadership roles in healthcare, like I think it's always good to be trying to ask that question of like, how can we deliver this care before the person's sick, or how can we detect disease earlier, rather than just like trying to optimize once a patient's already really sick.
Adam, I was wondering, are these AI applications, are they a lot of them interfaced, or do they get just fed information like reports and data out of the EHR or whatever?
Yeah, so like Mayo Clinic, what we have built and are continuing to build is like, yeah, like integration tools into the EHR. So like we have tools that like a company can take their product and put it into like a little box in the medical record system, where it has like all the context of the patient and the information from the patient pulled into the algorithm. So yeah, the program I work in, it kind of depends. Some of them like
Okay.
are part of the EHR, some of them are like not necessarily an EHR based product. But like yeah, we also are building tools that are, allow organizations or allow algorithm developers to have a integration into the HR.
Okay, great.
That's a good question.
Do you ever meet resistance from like government, from legislature, in the courts about AI and how reliable it can be?
Um, you know, I think my impression from like the last couple of years being in this role, like I think there's definitely a more like deregulatory bend right now. Like the FDA, I think, is like less interested in like having really harsh regulations around AI and is more interested in like getting AI out into the real world and like letting people see how it works out. So like whether that's good or bad is like, is kind of personal preference. But um yeah, I mean, there is a lot of challenges as well, like especially over the ownership thing. Like you probably already know about this, but like training generative AI and like was it legal to take the entire internet, including like copyrighted data, and use that data to train algorithms like ChatGPT? I think that's a big question in the industry is like when these companies get sued, like the New York Times suing OpenAI over ChatGPT.
Yeah.
Like I think the outcome of that lawsuit might be pretty consequential for the AI industry because like if it's determined that they did steal all this content and data, like AI is going to move a lot more carefully to not use data sets that are copyrighted. So yeah, I guess that doesn't affect my work as much because like we um, aren't like we don't use copyrighted materials that aren't ours. But yeah, for other AI companies, that's going to be a big concern.
Yeah. I was just thinking, if a physician made a mistake or something and you had to go to a lawsuit and they used AI for some reason, um, you know, how how would that go in the courts?
That's a great question. Yeah. And I think like I know my wife, she worked on a research project with a company called like OR Black Box. So they're a that's a product where essentially they have like a camera that they put in the operating room and it records the entire surgery and has like
Okay.
some AI analytics around the surgery. And yeah, a lot of doctors are concerned about that, like, oh, like everything I'm doing is being recorded. Like, what if somebody sues? Can this be used against me?
Yeah.
Like I think that's gonna be a big question with a lot of AI algorithms is like, what happens if I trust it and it's wrong, or what happens if I don't use it and it's right? Like, is it just as bad to ignore an algorithm and then give a treatment that ended up being the wrong one? Or is it, just as bad to use the algorithm and then it's wrong?
I guess more data is needed.
Yeah, I think it's still pretty early on in the
Yeah.
the learning about how that's going to work out.
That's really a good point because in medical records, I mean, you have your designated record set and your legal record, and then you have the administrative record where things like a patient took a fall at a nursing home or results from a quality check done that never gets released. So it's just like, how would they control that with the broad spectrum of AI? You know what I'm saying?
Yeah, exactly. Like, does the result of every algorithm that was run on a patient get saved forever, and then it's something that could be discoverable in a lawsuit or something, or is it just like information that's there for a second and thrown away? Like I think it's a lot of open questions on that.
Yeah.
Hmm.
Thank you.
Yeah. This was
And
great,
just have
Adam.
one more question. I
Sure.
just have to ask it.
Sure.
So, hallucinations, do you guys run into that? Have you like worked out the kinks of that? Is there like a difference between Mayo's platform and just general chat GPT? Because I know the other day when we were playing around with it at work, someone said they typed in their new user of Dragon, and Dragon was the transcription. And the co-pilot said literally how to train your dragon. And it so I'm kind of wondering if you guys
That's
ever
funny. Yeah,
you ever
I
run
would
into
say. Yeah, the hallucinations. Yeah, I mean that's a big concern with generative AI is like validating that what it's saying is true. I think the solution for that right now in healthcare that's kind of out there is like almost everything being reviewed by a person. So like even like a bridge or other generative AI solutions, like they don't just write a note and then it's posted and it's final. Like a lot of these tools, yeah, they generate something and then it's reviewed by a human being and it still saves a lot of time because like you don't have to do the first draft. Um, but I think it's going to be a long time before like AI is automating tasks. It's right now it's more about like supplementing human beings.
Right. Yeah.
Yeah, but I think the AI is pretty close to solving a lot of the hallucination stuff. Like I think that new like Gemini 3 model and like I think every year the models get better and better at reducing hallucinations. Like that's kind of one of the main goals of a lot of companies right now.
Do you still so the records that you go through and what you do, I saw an article that the data has to come from like releases that patients have signed. Is that still something, or can you just use the de-identified data without the patients knowing, or
Yeah, I'd say like any organization can't use patients' data without them knowing. Like like at least legally or ethically. So yeah, like especially at the data set that I would, work with in my role, or any data set like Mayo Clinic would work with, like, yeah, the patients would all have to have given a consent for their data to be used. So like patients who don't consent, or their data is taken out of any research data sets or any de-identified data sets.
Okay. Thank you.
Any last questions for Adam? All right. Well, thank you so
Yeah.
much for being with
Thank
us,
you.
Adam.
Yeah, have a great night and good luck
Yep.
in the rest of the MHA program, everybody.
Thanks.
Bye.
All right. Well, I got about 7 o'clock. Should we take a 10-minute break and come back? All right. I did forget to pause recording, so
I feel like me and Angie were just sitting here waiting for someone to come on so we could.
oh funny. I started loading the dishwasher and I'm like, oh, I better get back there. All right. Here, I'll share my screen. Okay. So, I haven't because Nate loaded these, you guys are gonna have to tell me whose is whose, okay? Um, and and of course Dominic's not here. So anyways, um, do you want here? I'll see. This is the first one. What is this? I don't know what this is. This isn't from one of you guys, is it?
Uh-uh.
No.
No.
And I didn't see my app on there or my
I might
thing
have to
on
have
there.
this. Okay, that's what I was wondering. I was like, I don't know if he loaded these, but are these your healthcare innovations?
Not mine.
No.
Okay, then I'm thinking he didn't load them. So can each of you, are you willing to share your screen
Sure.
and do all that? Okay. All right, I'll quit sharing and there we go. Who wants to go first?
I
Don't all
can
jump
get
in.
it over with.
Okay.
Okay.
That's what I was wondering. I was like, I don't know if any of these are for you guys. So,
Let me see.
all
How do I
right.
want to do this?
I'm gonna pull up my notes
Oops, I
here.
gotta sign back in.
Yeah, no rush.
Okay, share screen. Can you see it?
Yep.
Okay. How do I make it
Yeah,
slideshow?
I was gonna say, yep, just click on that. There you go.
Oh, maybe I don't need to. Doesn't say though.
Are you looking for your notes, Angie, or
No, I have
oh,
on there, but if I go to this whole screen, then it takes off
takes your
half of
notes?
them.
Yeah.
So I'm not sure how to get it on there without.
And you just have the one screen?
Yeah.
Yeah.
Okay. Well, I guess I'm just gonna have to do it like this. Can you see it though?
Yeah. Mhm. I
Okay.
want to say you could share it with me and then I could pull it up if you want it, and then you could have your notes.
Okay. I think I sent it to the MHA.
Yeah, and I don't have access to
Oh,
that,
okay.
Angie.
Okay.
So, but you could just go up to share and then share it with me right there, and
Okay.
then I'll get an email. Okay, perfect. Okay, there it is. All right.
So I'm gonna stop sharing.
Yep.
Okay.
All right. Slideshow. All right. How about that?
See, it does it on yours too. I don't know
What?
why it's cutting that off.
Oh, this. I just had to
Maybe there's
click.
animations. Yeah.
Oh, there you go. Okay.
You were just getting fancy and you didn't even
I
know it.
guess. I guess. All right. So, my innovation, NutriConnect app. So, I think one of the things that Americans struggle with is nutrition. And I think that, as we grow up and we go to school, it's not really taught in the schools. And um, there's a lot of bad food and a lot of good food. And unfortunately, the lack of education is a huge part in the United States, basically. So the problem definition is chronic diseases are heavily influenced by poor nutrition and lifestyle choices. And patients often lack timely, personalized guidance on diets and food decisions. Social determinants of health, income, education, food access make it harder for vulnerable populations to get expert nutrition support. And current healthcare systems are reactive instead of proactive, trying to prevent the disease. So I proposed this NutriConnect app, which is a 24/7 direct access to nutritionists via chat, video, or AI assisted triage. It's personalized meal guidance tailored to chronic conditions, cultural preferences, and local food availability. Um, Integration with grocery and meal delivery services. So people can, go on a Saturday or Sunday and load up for the week, so they don't even have to think about it. It's just in their app and they look at and see what they're making for dinner. That is a healthier option every day. So it's quick. Health tracking, there's rewards for meeting your nutrition goals, community challenges, and progress dashboards. And then data integration with your Apple smartwatch or Fitbit to address nutrition in real time. Why it's a problem we're solving. Chronic diseases account for 90% of US healthcare costs. Nutrition is the most modifiable risk factor for chronic disease. Patients face a lot of barriers, which are lack of access to dietitians, high costs, and limited appointment availability. Sometimes it's very hard to get into a nutritionist because of all the people that need to get into them. And a lot of people work as well. So they work daytime hours, and it's hard to get in if you're working during the day. So, um, my implementation strategy would be partner with hospitals, insurers, and clinics to offer the app access as part of the chronic disease management program. It would be subscription based, covered by insurance by your employer, or there is a free tier that would be able to give broader access to everybody who doesn't have either insurance coverage or um, employment. And then, the design thinking process would be empathize, understand what the patient is going through and what they're struggling with, define the lack of accessible nutrition guidance as the root cause, um, create a digital first nutrition platform. And then I would pilot it to a small patient group first to see how it worked and how they thought it was before going on a larger scale. And then when they came back with feedback, I would refine the features based on the feedback and outcomes. So my Shark Tank pitch would be NutriConnect is the Uber for nutritionists, always available, personalized, and affordable. By tackling nutrition, the most powerful level in chronic disease prevention, we can reduce healthcare costs, improve patient outcomes, and empower healthier communities.
Great.
Thank you.
Thank you, Angie. Thoughts?
Good job, Angie.
I love the idea.
Yeah.
I do too.
Good idea.
I
Nutrition.
know it's a good idea. Would it really be used? I don't know.
Probably by the 30% of the population that regularly goes to the gym. Everyone
Well,
else
and
is
then you have older generations who don't know how to use, electronics, and not everybody has
Mhm.
access to internet. So
Yeah.
there are some things that would have to be modified as well.
Yeah. Yeah, for
You're
sure.
supposed to sell it to us, not de-sell it to us.
There's
Well, my pitch
always
was over.
Now she's playing devil's advocate. Ah,
Yeah, and I think those are the social determinants of health, right, Angie? A lot of those barriers. I know I was working with a group of clinics down in the Twin Cities that were trying to get their patient populations comfortable with telehealth. And I don't know, I live in a very rural area, right? And I know internet
Hmm.
can be an issue and things like that. And I guess I just had an assumption. I know we shouldn't assume, but I had an assumption kind of going in that it wouldn't be necessarily a problem for those living in the Twin Cities to have access, whether it's on their
Sure.
phone or whatever. But every single population, like one clinic had a greater Native American population, one clinic had greater Hmong population, another clinic had more Somali patients. Um, and each group had such individual needs and differences in terms of their just having access to a phone, having access to internet. Um, you know, then you throw in language barriers, you throw in cultural barriers
Hmm.
and differences. And I can't believe how much I learned in just that one project. Like, that, for example, like the Native American group, like they just really didn't trust um, the healthcare organization,
Hmm.
And so it was like, how do you establish trust but then try to get them to feel comfortable using telemedicine? And it was just, I don't know, it was
Yeah.
just really interesting. So I think about an app like this, like it's wonderful,
Yeah.
but lots of things to consider.
Well, and in the Hmong population, they often look to the elders. Well,
Yes.
your elders are not going to, I mean, I don't
Yeah.
think that, I mean, maybe they are, but the elders of that community are probably not on the internet.
Right. Right. Yeah. And so
So,
so like at least during COVID, a lot of times it was like a grandchild or a daughter or son that were on the phone trying to
navigating
help
for
connect.
them.
Yes. Yeah.
Yeah.
Yep. And then you run into their availability and like all these things, right?
Right.
Yeah. But this was really good, what you put together, and your design thinking process was, right on target and things. Also, it just what our guest speaker shared tonight. I mean, it's perfect, right? This fit
Hmm.
right in with that. And
Hmm.
and Patrick's comment about that graphic that he showed, like taking care of this condition before it gets to be a chronic disease
Yeah.
issue. So, yeah.
Start at the root.
Yes, for sure. For sure. All right. Thank you. I'll stop sharing this. Okay, who wants to go next?
I can go next.
Okay, Patrick, are you okay sharing your screen, or do you want to send it to me?
I can share my screen.
Okay, perfect.
Um, yeah. Let's see. All right. Can you see it? Hold on. Let me present. Can you guys see it?
Yep.
Okay. So my innovation is also an app. Um, and actually the part of the that you were just talking about of his presentation that I commented on, I feel like could also interface with my app.
Hmm.
Um, so as a case manager, I've seen a lot of issues with telehealth as well. Um, and just with access to resources. So my app would essentially be a one-stop shop to access resources, receive health services, manage prescriptions, track progress, and more. Um, One thing I've seen with like telehealth nowadays is you have all these my chart websites, and they're hard to use. You never remember your password, and like what happens if you go to one hospital one day and then you go to another hospital and now like your information, it's hard just to manage all that. So this would sort of interface that all into one, as well as having more features that address some of the social determinants of health. um, I think one huge issue in a lot of our cities is food deserts, and that really can impact people with chronic illnesses, as a lot of them don't know how to access healthy food. There just aren't places to access healthy food, or it's too expensive. All which are completely valid reasons. So my app, I'm gonna move this screen. My app would sort of allow people to access um, a database of these resources on the app. Um, and I also see these businesses interfacing with the app as well by being able to push their products, by being able to offer coupons and deals and stuff. Um, Similar to the way that a lot of like you see these fast food places developing their own apps now, and they're able to offer deals and stuff like that. Now you could see smaller markets, or smaller shops, um, farmers markets, healthy food stores that don't have the resources to develop their own apps. They could use this to push out their product to people. And then on the flip side, the consumer side, consumers would be able to find um, healthy food, find these resources easier without having to just like, I don't even know how you find it now, Google, and then you have to combine. And yeah, so it would also sort of serve as a resource database, which is an issue that I've seen as a case manager. Is there's like, in order to find different resources for people, there's all different sorts of websites that you have to go to. This would combine everything and get it to one central location that would make it easier for people to access themselves without having to, you know, find it and go through this confusing mess. Um, Another feature of this website would be connecting with physicians and doctors themselves and being able to schedule appointments. And I see that this as being a valuable tool for that, because it's so hard to do now. Um, and I've seen that with my job a lot. You have to call and then you have to go through the whole phone tree. Okay, if you blah 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 blah, press one. If you blah 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 blah, press two. And that just like it takes time, and it's really confusing for a lot of people. So just having like an interface where you would be able to do all that stuff would decrease a lot of the barriers, and increase access to a lot of these resources that, for some people struggling with chronic illness, like have a lot of trouble, finding. And I could also see like hospitals could use this. If let's say a patient is admitted for something, um, they could, use their app, this app, to push out prescriptions to them, and so it have all the information on there, as well as like phone number, best like way to talk to your doctor if you have any questions, um, stuff like that. Have like a treatment plan for leaving the hospital that they could track their progress on. A lot of one issue that I've also seen with some of my clients is they'll go to the hospital, they'll get treated for something, they'll be sent home with like medications and then instructions on like tiny paper, and then it's just like they have such a hard time like doing some of that stuff for themselves, like remembering to refill their prescriptions or knowing when to take what, like without like specific instructions that are easy to access. That can be a huge barrier to treating their conditions. So having all that on an app, I feel like would make it a lot easier. And especially with how like available smartphones are nowadays. Like everybody has a smartphone. Even some of my most needy clients, it's pretty easy to get phones nowadays, and you can find smartphones that aren't Apple or some of the top brands for pretty cheap. So I found that a lot of people would be able to use this app. Um, so yeah, I feel like I kind of talked for a long time, but that's sort of my spiel.
I thought it was great, Patrick.
Thanks.
Um, it was everything you said resonated with me, and I could see where you're coming from. One question that kind of popped into my mind is, how could this be enhanced with AI? Like just based off the conversation we
Absolutely,
had
yeah.
earlier. What are some of your initial thoughts on that?
Well, that's one of the things of what he was saying in the presentation really intrigued me is how you can um, use AI in preventative care. And I feel like that's something that could definitely be used in this is like a little tab and you can sort of like tracking your progress of like going through and using AI to do that.
Mhm.
Um, Also like a lot of other places have already employed stuff like this, but like AI chatbots or
Yeah.
somebody to talk to like answer your questions. Obviously like it would be better to get people connected to like actually talk to somebody.
Mhm.
But if there's a lot of people that are using this, like sometimes it's just hard to find somebody to talk to like at that second. So I guess like you could use an AI chatbot. Um, yeah, I don't know. I see a lot of opportunities for AI in this and
Mhm.
just other opportunities in general.
Yep. Angie, did you have comment?
Oh, I was gonna say, so I saw this thing I was looking at earlier, and they say a lot of people are using ChatGPT for therapy. So that could be another thing that you
Really?
put it. Yeah, they say because it's free and you can do it
Yeah.
anytime, right? So people are like,
I could definitely see that. Yeah, I just recently saw something of like it giving bad advice. So I would definitely like really want to be cautious with that.
Oh
yes,
my God.
And
yes,
maybe like change the
like,
algorithm a little bit to make it more, safe and or catered specifically for therapy.
mm-hmm,
But yeah, I definitely think there could be something there. Obviously,
mm-hmm,
like it's always better to talk to like a human,
yeah,
especially for like therapy. But with just limited access to that, or like maybe if it's like an acute situation, and it's the middle of the night and like you might not have somebody to talk to. Obviously, there's like
Yeah.
the suicide hotline.
mm-hmm,
This
yeah,
maybe could be like a step below that.
right,
Someone's scared to call the suicide hotline because of what do you call it? Stigma surrounding
Sigma.
that.
Yeah.
Maybe
mm-hmm,
this is a little more
mm-hmm,
private. We could use that.
yeah, yeah. I just thought that was interesting because, it doesn't cost any, or I mean, if you got the upgraded version, it would cost something, but for the free version, people
Yeah,
are like using it as their therapy.
I don't know why that's shocking to me, but it kind of was like you kind of like
yeah.
Mhm.
You can have
I
a
don't
full conversation with them.
nothing
Absolutely. People are
nothing.
like falling in love with ChatGPT,
That's crazy.
their partner or
Oh my
whatever.
goodness, Angie.
It's crazy, but I mean, I can see
Yeah.
the therapy thing.
Yeah. Wow. One thought I had, Patrick, as you were talking, as I was thinking about AI too, was just, your phone's tracking everything. So if it was tracking your location, like to even pop up and tell you, oh, here's a bus stop, a block
Yep,
away,
yep.
Hmm.
or here's some coupons for this store that's right down the block from your clinic or wherever you are.
That's
Um,
true. Yeah.
I don't know,
It's this
just
other like I saw this recently. There's like an add-on for like a search engine that you can get like when you're doing shopping online. So you're like on Amazon or any website, like you can like take down a tab and it'll search the website for like the best deal or like stuff
ah,
like that. So some of that technology could totally be like used with this.
yeah, yeah, for sure, for sure.
The only thought that I had, Patrick, when you talk about like the scheduling of appointments or plan of cares or whatever, the only thought then, which is a good idea, but the only thought I had was like the regulatory surrounding that. Like a lot of that's PHI, you know.
Yes, definitely. Um,
I mean, I suppose it would be possible, but there'd have workaround on that,
Yeah, that's a good thought. I don't know like specifically all the regulations around that. But I know like especially having an app with like sensitive information on it, like about your prescriptions and stuff, like that's definitely something you'd want to take seriously.
Mhm.
Um, I know just like obviously you could have like thumbprint lock to like get into the website. Like I know like some of those banking websites have it or like insurance websites. But as far as like specific regulations surrounding health information, like yeah, that's definitely something to look into. Yeah,
Mhm.
I know my chart has an app, so as you're talking about this, I'm like, how could they like integrate something like to put a platform on something like this? And it'd be a
exactly.
really, really good idea. It's just, and I'm sure it could be done. They just have to like be careful with the regulations and the workaround, the legalities.
For
Mhm.
sure,
But I
for
like
sure.
the thumbprint lock. That's a pretty, biometrics. That's a pretty good idea.
Mhm.
Yeah. Or like the face scan, like Apple has that
Yep.
face scan now getting this stuff.
Mhm.
Password protected.
Yeah. Very good, Patrick. Thank you so much.
Okay, I'm gonna stop sharing.
Okay.
I sent you mine, Katie, and I'm sorry I did not create an app.
Oh, didn't have to
But
do that. That's fine. Here, do you want me to share, Becky?
yes, please.
Okay.
It's just easier for me.
Yep, no problem. Okay, there we go.
So I kind of took mine in a little more systemic approach.
Mhm.
Chronic disease, when I think of chronic disease, I think of like, stuff we have to live with, like certain people get cancer or whatever. Um, so my stats were in 2022, 19% of the US deaths were related to cancer. 49.2 million adults reported using tobacco products, a cancer causer. Red dye number 3, which was very, very recently banned in the US food industry. Interestingly, though, it was banned since 1990 in cosmetics. I want to talk on that a little bit. So, red dye number 3 has only recently been banned in the US, even though it has been known for years to cause cancer. It was banned by the European Union in 1993. The United States only banned it in 2025 after California did so in 2023. Although the US is giving manufacturers until 2028 to remove it from their products. Interestingly, this dye, as I said before, has been banned in cosmetics since 1990. That came from a Dwayne Morris article on the FDA ban. So then talking about government regulations, according to an article by GoodRx, the FDA uses a system called Generally Recognized as Safe, or GRAS, which essentially means they believe ingredients used in food are safe unless research proves otherwise. Another hole in the system is they take expert opinion over rigorous testing of new additives. The alternative to this questionable process is what European Union regulators do, which is they make the manufacturers prove the additive is safe before they allow it on the market. According to the FDA website, manufacturers are in charge of determining if their additives meet GRAS status, and if this is the case, the FDA does not perform a pre-market review. So essentially, it's like letting them govern themselves. Um, so I think this whole thing could be the whole cause of chronic disease systemically could be a lot could be done through reevaluation of how we regulate what goes into our bodies, right? I mean, it's on there. I have regulated in quotation marks because I found out that in 2024 the FDA's budget was $6.9 million. Of this, 52% was funded through Congress, 48% from user fees, which are the manufacturers who are looking to hit their products to market. Regulatory capture, new term I learned. Regulatory capture is the term that describes the quote unquote governed industries which pay most of the regulators' costs. So you have Philip Morris, tobacco companies. You see on my slide there, I found that they pay 100% of the regulatory that comes out of FDA. um, So, of course, this can turn into a purchased license to market in record time. Get this, the experts used in this case by the FDA are often former regulators. Industries have been known to offer future jobs in exchange for favorable regulatory decisions. Well, obviously, that leads to corruption. So, taking all this information together, I think tighter regulations on our FDA system and looking at what the European Union does would be a great benefactor in stopping or stalling or even decreasing chronic disease, because it's a well-known fact that a lot of it is because of what we put in our bodies. And I mean, it's obviously a person's decision to smoke or do whatever, but a lot of things we can't avoid. I mean, if you're some preservatives, red dye number 3 only recently, banned, it's like, yeah, what's going on here, But
Hmm.
that was I didn't
Yeah.
do an app, but I did my design thinking was change the system.
Yeah. Well, it feeds right into Angie and actually Patrick's
Yeah.
apps. So no, it's great. I think you did a good job. Your research was really interesting too,
Well,
Becky.
thank you.
It's it's kind of just
And scary. It's
scary and
scary.
frustrating and sad, like it's kind of all just corrupt and
It
I don't know.
is. It is. And
Yeah,
then too, I did find out too that the food industry only funds 1% of that. Okay, so I gave them the benefit out there, but the pharmaceutical industry funds 75% of the FDA. Now, again, what does the drug industry treat? Chronic disease. Where does chronic
right,
disease come from? Food.
right.
So that's why, in my mind, that's why I figured the food industry doesn't have to pay them that much because the drug
Yeah,
industry has taken over.
yeah. And now they can just put everybody on,
Yep,
Ozempic
Drugs.
or
Hmm.
yep, or Cialis, or
yeah.
it's
Oh,
so
It
sad
all
we
comes
know
down to
these.
the almighty dollar. That's
it
what
It
it
really
comes
does.
it
down to.
really does,
It
Angie. Yeah.
does. It's so
It's
sad
terrible.
we know these brand name drugs. 30 years ago, you're like, well, it's just whatever my doctor puts me on?
Yeah. Yeah.
Well, you have to be educated now, or, they'll just throw these pills at you and you don't know
Yeah.
what, you know, it's
Yeah.
scary.
Hmm.
Yeah. Interesting. Well, thank you. That was really great.
Yeah, no
Great
Um,
problem.
facts.
yep.
Thank you.
All right, I'm gonna stop sharing. All right, you guys. Um, so I was looking ahead. Here, I'll pull up the slides. Give me one sec. Here we go. I still have to grade your papers. I'm working on it. Um, I don't know if you heard David. David ended up going out. His father was discharged on Tuesday on hospice, and so um, I had to kind of jump in and help out with the final capstone course. And so my time has been split this week between my regular duties and then trying to prepare for Saturday and figure out everything David was going to do. So I appreciate your patience with me, but I will try to get those graded tomorrow. Um, and then this is this week, as you guys know. Um, Um, I think you should have access to the course evals. Um, I'm sure you're all working on your final paper. I did want to ask one quick question about the discussion topic. So now Dominic didn't attend tonight, and would he would post his slide, and then you all would go in there and view it this week and comment, essentially, right? Is that
Yep. Hmm.
okay?
Yeah.
Okay. All right. Just wanted to make sure I understood so I know what to kind of expect in terms of grading that. So, and then um, and next week, guys, I'm still working on a speaker. Um, I have now sent my contact 2 emails with no response, so I'm getting a little nervous. There is a chance I might just cancel class if I can't get somebody. I do have 2 other contacts though that I'm going to reach out to in hopes that they can maybe speak to you on disaster preparedness. So I will keep you posted on that. But yeah, it's mainly just your final research paper, and you guys are done. So.
I gotta get that bad boy out.
So if class is canceled for next week, should we just put our discussion online then,
Yeah.
or?
Yeah.
Okay.
I'll let you know, Becky. I'm hoping I'll know by, I don't know. Maybe give it till Monday and then but the problem is this is a short week. So that's why I'm like thinking, how's that discussion gonna work? I'll think about it. I'll send you
Okay.
instructions.
Yeah, just let us know.
Yeah, it might be hard to get a discussion in next week. So we'll play it by ear and see what happens. Any questions on anything remaining in the course?
Nope.
Okay. All right. Well,
Ha-
it
Have
was
a good
great.
night.
Yeah.
I have a question for you. Sorry, I sent you an email, but you're really busy, so it's just easier to ask you. Um, Book for next semester's spring. Is that something we're gonna need throughout the whole program or something we can just like rent for a few weeks?
I believe you can just rent it for a few weeks, Becky.
Okay.
I think I did peek at your email. Um, and I thought that, are you all taking the quality course next in the spring? Is that what it was, Becky? The quality course?
Think so. Yeah.
Healthcare quality and safety. Yes. So I would,
Yeah.
you said you can go from 180 days all the way up to a forever license. And I would just say do the minimum. I mean, it's a 16-week class,
Okay.
right? I believe it's 16 weeks, or is it 8 weeks?
I hope it's
Uh,
yeah, I hope
8.
it's 8 because that's the one that starts at 5, right?
Is it the
I'm sorry, you guys. I should know this.
Oh, that's okay.
wait,
Okay.
I'll
We
look.
should do it too, I guess.
Spring.
What we're doing next spring.
Well, it's an HIM course, so that's what I should know. But
right?
Oh.
I feel like I've been looking at this course schedule for spring like 100 times. I can't keep anything straight anymore. So give me 1 second. I'm pulling up the schedule though, and I will be
Doesn't
able
it
to.
start in January though?
Yeah, that's what
Yeah.
I think
Oh,
so.
okay.
But
But they call it spring.
there's
Yeah.
spring 1 and spring 2, and then there's the full term.
Got it.
So that's where so it's HIM 65.
Like it might have been asynchronous.
It is, no, I think there
No.
is some synchronous. Oh,
Isn't
I'm
this
sorry.
the
It's not an HI. So here's the
one?
deal, guys. This is where my head's getting all mixed up. It used to be HIM course, but when Sue took over and started the MHA program, she really wanted it a part of the MHA program, and so we transitioned it over to MHA. So it is MHA 6506, and it is yes, there is synchronous sessions Wednesdays 5 to 7, um, and it is spring 2. It does not
Oh,
start until
good.
March 16th
Oh,
and goes
good.
through May 7th. So it's a spring 2 course.
What's the first one then? Do we need any books for that? Because I didn't see it
Is
pop
it
up in the.
project management or something like that?
Well, that's what I was wondering
HIM.
because I don't think you guys are taking the other two MHA courses that are offered are healthcare finance 2 and health services leadership. And health services leadership is the very beginning of the program, right? I
Yeah.
Yeah. And healthcare finance 2, you would need to have the first finance course, and I don't believe you've had that yet.
No.
One
So
I'm confused because the one that's on my schedule says HIM 6524 and it says asynchronous for spring 1.
yep. Okay, so that's correct. So you are having, yes,
So
that's
mine's a little bit different then.
Amy
Okay,
Waters is teaching that. Yes, and that is an HIM course. Yep.
got it. Okay,
She
cool,
built that with Sue. Yep.
cool.
And it is asynchronous except for I believe the final like presentation will be synchronous.
Okay,
So, mhm.
good to know.
Yep.
Question for you too, Katie.
Yep.
So with my new job, I gotta go pick kids up at daycare and move them around. So that I'm a little nervous about that. Class is starting at 5 in term 2 because I think
Mhm.
that's synchronous. And I talked to Sue and she's like, "Oh, you'll be fine, whatever." So with her gone, I'm kind of like, "Will I still be fine? I hope I'll still be fine." Because there might be some days I might have to log on late, or I mean, I could like log on my phone as I'm driving with the camera off or whatever. But I don't know, and I don't think you teach that one. I don't know what the
I do
teacher will say.
not. I do not. But it's Susan White, and she's taught it now since it became an MHA course. So 2 to 3 times she's already taught it. I don't see that as being a problem, Becky. But what you could do is if you could remember at the beginning of the course to email Susan, your instructor, and copy me on it.
Okay.
And and then we'll go from there. And you can even say, I discussed this with Sue and I discussed it with Katie, and we they understand that This is life. We have to work around it. And
Right,
so, Becky, you
right.
got to do what you got to do.
I know.
Yeah,
I told Sue I'm like 5 o'clock. She goes, I know, but she says she's in Florida and
she is.
she didn't want to
Yeah,
put it later. I'm like, okay.
yeah,
I'm like, thank God. I think that's the only class that's at 5. So I'm like, thank God for that.
yeah, yeah. So this is life, right? And so
Right.
just if you can try to remember to email both of us, copy me on it. That would be great, and I'll support you in that. So,
Okay.
yep.
I
Thank
I
you.
have
have a
organizational behavior as the next course
Okay,
for
so
it.
that's a management course. Yep. So, um, I can't tell you much about that.
Yeah, that's
Um,
okay.
Situational behavior.
I'm
Yeah.
assuming that's one of the ones we share with the MBA.
Yes, it is. Don Johnson is teaching that Tuesdays, 5:30 to 9.
Whoa.
Yeah. Do you have that too, Patrick?
no, I don't have that one, but I
Oh,
was gonna say I have a similar situation with conflicts for that second
with Susan.
spring two class.
Okay.
That's the one I'm in, and I am on baseball team, and I
Ah,
have games. Looks like scheduled every Wednesday, April 1st uh through the end of April.
okay.
And
So,
so I think that I should be okay for some of them, but
okay.
not.
Yeah, Patrick. So here's the deal. So I think what I would like you to do is also email both of us at the beginning of
That's
the
what I was thinking.
because I will tell you that so there's a little the difference between the masters in HIM and the masters in healthcare administration is that we we market our program, the HIM program, to be pretty much completely asynchronous, right? And so when Sue took over the course and she wanted to make it synchronous, we said, okay, but we have to have an exception for the HIM students because they went into the program thinking that it was completely asynchronous.
Hmm.
So what we've done is that there's like the caveat is that if you don't participate, it's very much like this class. If you're not able to be there in person, then you do the online discussion forum. Or she might have, but the course is set up where there is a structure and assessment activities for students that cannot attend the synchronous
Okay.
sessions. So you
Okay.
should be fine with that, Patrick, but just like I told Becky, a reminder email and explaining that you're in baseball and
Okay.
your schedule game schedule.
I
So,
will be sure to do that.
yep. And I can definitely reply and say, yes, please handle this as if he was like you would for the HIM students.
Okay. Thank you.
Yep, you're welcome. Any other questions about your spring schedules or the program? Okay. All right. Well,
Thank you.
yeah, really great class tonight, you guys, and thank you so much for your hard work. 1 week left. So
Yes. Just let us know what we need to do for next week.
I will. I will. You know
Thank
what?
you.
How about my goal is by Friday end of business, I will let you know what the plan is.
Yeah,
Okay.
no worries. I'm good with
Okay.
Monday too.
Okay. All right. Sounds good, you guys. Have a great evening.
You too.
You too.
Bye-bye.
Thank you.
Bye.
Appreciate
Bye.
it.
Yep.